Hi, my name is Andrew Rule. I am a professor of medicine and practicing nephrologist at the Mayo Clinic in Rochester, Minnesota. I'm going to discuss a publication called Stone Composition Among First-Time Symptomatic Kidney Stone Formers in the Community. So this publication basically describes what the composition of kidney stones are among first-time stone formers in the community. It's important to remember that kidney stones are very common. We and others have shown that about 7 to 8% of the general population has kidney stones. However, most studies on kidney stones have been done in referral populations, typically patients seen in stone clinics or urology practices where they're enriched for rarer and more complicated stone cases than the average patient. So we have instead elected to study first-time stone formers in the community, and we reviewed their medical records from 1984 to 2012 for stone formers in Olmsted County, Minnesota. And we found that stones are actually more likely to be common calcium stones than has been previously reported. So typically, it's been reported that about 75 to 85% of all stones are common calcium stones. That would be a stone composed of hydroxyapatite or calcium oxalate. Instead, we found that it's closer to 93%. And we've also found that uric acid is much closer to 5% rather than 10% of all stone formers. And then stone types like brushite, struvite, cystine, these are extremely rare, less than 1% for each of these. Actually, cystine is even rare, about 1 in 1,000 of all the stones we see in the population. So this has some important clinical implications, because if we can identify the stone composition, we can more accurately start the patient on the right therapy. Now, one of the problems is, and this has been described before, is that many people do not get a stone composition analysis. There are both physician factors as well as patient factors for why this occurs. It's inconvenient to save your stone, or it passes and the patients do not know where the stone went. It goes down the toilet. A lot of factors come into play here. So we've found that only about 50% have a stone composition analysis available. So we wanted to know if you could estimate the composition based on clinical characteristics and laboratory tests in patients who don't have stone compositions. Unfortunately, the answer to this is you really can't. What you can say is about 65% of all stones are actually composed of what's called calcium oxalate monohydrate. If you developed a model to more accurately classify stones, you could accurately determine the composition in 69% of the time. So really, just assuming it's a calcium oxalate monohydrate stone does just about as well as trying to use a more complicated model to determine composition. The other thing we looked at, how does this relate to recurrence? So what patients want to know is is whether or not they're going to have another painful kidney stone episode after their first episode. And so we've developed tools to predict recurrence. We've published the ROCS nomogram, ROKS, you can find it on the internet, to estimate your risk of recurrence. And what we found in this study is that composition does help you predict recurrence. We previously reported that uric acid is a high-risk composition for recurrence, but we now have shown that brushite and struvite are also high-risk compositions for recurrence. The lower-risk stone types are the hydroxyapatite and the calcium oxalate, though we did find that among calcium oxalate stones, those that are calcium oxalate dihydrate were a little bit more likely to recur than those that were calcium oxalate monohydrate. So we've actually have modified our nomogram to recognize that brushite and struvite are also high-risk characteristics for recurrence, and this information will allow patients and clinicians to better estimate risk of recurrence, and this can be used to help decide which medications or which dietary changes to make to try and prevent stone recurrence. And I would just end with one other comment. Practice guidelines disagree on the importance of stone composition. The ACP does not believe there's enough evidence to warrant stone composition analysis in routine stone formers, whereas most urological societies do. And this study provides additional data to help further address the questions as to which patients should have stone composition analysis performed in order to improve their care. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.